So my name is Breanna Johnson. I am a fourth-year medical student at the University of Tennessee Health Science Center in Memphis. And my study is on empowering adolescents through bystander training and educational approach to improving emergency outcomes for adolescents in Memphis, Tennessee. And this project was started by Dr. Chelsea Miller when she was a student at UT, and then I carried it on after she left. So first of all, I have no disclosures. Just to give some background on the study, there is a critical gap in time between an emergency incident occurring and emergency medical services or EMS arriving to the scene of an accident. And this critical window allows time for bystanders to intervene. And when we empower bystanders to act efficiently and encourage them to act in emergencies, we have the potential to reduce morbidity and mortality rates. And UT is located in Memphis. This is also the city I grew up in. And unfortunately, it has a high violent crime rate and very long EMS wait time. This is for several reasons. First of all, there's only 34 EMS units in the entire city of Memphis. Also, the Memphis Police Department has to clear a scene before EMS personnel can attend to any victim. And there's also the problem of people using EMS as a primary care service, or they're just not sure what is a true emergency and what actually warrants a call to EMS. So all of that combined results in long EMS wait times, which is obviously detrimental to the victim. And so this is even more of a time for bystanders to intervene and potentially help victims in these situations. So the goal of the study was to assess the impact of a bystander training program on adolescents' preparedness and confidence during emergency situations. So this was a pre-post study. Enrolled in the study were 210 students aged 14 to 18 in Memphis inner city schools. And the training course was taught to teachers who then taught the course to their students so that we could have it taught over multiple class periods and enroll larger sample size. It was a course on theoretical knowledge as well as practical skills for common emergencies, including asthma attacks, diabetic crises, heart attacks, and bleeding injuries. So for instance, for the asthma attacks, we taught how to use an inhaler. If there was no inhaler available, we taught how to clear the airway or how to help a patient slow their breathing. And then the training course also included information on what a true emergency is and what should warrant a call to EMS versus what can be followed up with a primary care doctor later. And then it also included some information on interacting with EMS personnel and what information is pertinent for them to know, like if you gave the patient an aspirin before they arrived. And then data collection was made with a self-made questionnaire that assessed the students' knowledge scores and their confidence in handling various emergency situations. And it was given pre and post training course. So the results of the study, on the left here, we have a graph showing the students' self-reported confidence in identifying what a true emergency is and what warrants a call to EMS. So we have our pre-survey over here in 2019, and then our post-survey in 2019, and then for 2020, pre-survey and post-survey, and then statistical analysis of these combined gave a p-value of 0.0217, and a p-value of less than 0.05 is considered statistically significant, so these results were significant. And then in the middle here, we have the students' self-reported confidence in interacting with EMS personnel for the pre-course questionnaire versus the post-course questionnaire in 2019. the p-value was less than 0.0001. And then for 2020, the p-value was 0.5505. So it was not significant in 2020. And then over here, we have these students' self-reported comfort level in identifying and acting in the various emergencies that we taught during the course: asthma attacks, heart attacks, diabetes, and bleeding. And the combined p-value was 0.0159. The p-value alone for 2020 was not significant. There are a couple reasons for that. First of all, when COVID started, a lot of schools went online, so we were not able to get as large of a sample size as we were in 2019. So we think the small sample size may have skewed the results and gave not as reliable of a data set as we had hoped. There's also the Dunning-Kruger effect, which says that we taught them more than they thought they initially knew. So maybe their confidence was overestimated in the pre-course. And then when they learned more, they realized that they did not know as much as they initially thought. So some conclusions we can draw from this study. First of all, bystander training in schools significantly improves adolescents' readiness to handle emergencies and empowers them to interact and to help victims and potentially reduce morbidity and mortality. Also teaching them the difference between a true emergency versus what can be followed up outpatient has the potential to reduce EMS burden. And then additional studies are needed to evaluate the long-term impact of this study. So for instance, knowledge scores could decrease 6 months out and a refresher course may be necessary.